see some, we'll try to go through the presentation first, talk about what the information blocking is about. And then at the end, we have some discussion question, longer discussion questions in the polls that we're going to open up. And hopefully, yeah, we'll get some good participation from the community to see what everybody, how everybody's are interpreting these rules, and so on. So that's start. So next slide, please, Rachel. So first question really is that, do you know information blocking is a thing? And again, we'll put this to 30 seconds on the timer, start now. And yeah, we'll see how people respond to this. So most people know about it. Some people know somewhat. Yeah, doesn't seem, it doesn't, oh, there are some people who didn't hear about it. Okay, so that's at least good. And even if people know about it, I think it's been a kind of a confusing thing to navigate through. So we'll let the poll run and we'll go to the next slide. So that's good. So as an informatics fellow, you know, are you involved in helping your institution to become compliant with information blocking provisions? I suppose this actually relies on you knowing what the information blocking is or have some knowledge about it. So that's good. Wow. 40% of us are doing something about it. That's pretty cool. Yeah, I'm not sure. Okay. All right. That's cool. Looks like we got quite a bit of community participation in information blocking. Okay, so next slide. Let's talk about, let's get into it. So today our goals are to talk about the information blocking, explore some considerations for clinical implementation, and show how we as institutions can interpret the rules similarly and differently between various sites. And then we'll open up for discussions. Please keep in mind that what we presented here are to the best of our understanding. And if we made mistakes, please definitely let us know. Next slide, please. Let's talk about the background. So the 21st Century Cures Act was actually passed in December 2016 by the Congress. And then ONC put out its finalized rules on May 1st, 2020 to go into effect June 30th of 2020. The Cures Act has many different parts. There's the certification program for health IT developers, we'll call it HIT from going forward. The voluntary certification program for pediatric healthcare providers, as well as information blocking. And today we're only going to be looking at the information blocking provisions, what constitutes and what does not constitute information blocking. As we understand right now, the official compliance date is defined on the Federal Register as November 2nd, 2020. However, the ONC is extending a what's called discretion enforcement timeframe by 3 months due to recent COVID, which will make the new enforcement date February 1st, 2021. Next slide, please. So let's define information blocking. To put it very simply, it's basically what we, the actors, do to interfere with patients getting their own electronic health information, EHIs, or that we are blocking other providers getting EHIs on the patients that are caring for. The healthcare provider category is going to be most applicable for almost all of us, if not all. Please keep in mind that some of us work in systems that participate in health information networks like multi-hospital systems and health information exchanges, like some states have sponsored information exchanges. In addition, if you happen to market your instance of the EHR to the community provider for them to directly access, you could be considered a HIT developer. And why is this important? We'll get into that in just a bit. Next slide, please. So let's look at some information blocking examples, both concrete and hypothetical. If a patient asks me surgery notes and pathology results, and I, as a hospital, do not supply that, I could be blocking that information. If a patient asks me for lab results on the patient portal, and rather than giving the commonly understood names and the result value, I give them instead some kind of proprietary formatted data that only I can understand, that can also be information blocking. If a patient is a customer of multiple hospitals, including mine, and I, the hospital, choose to make it hard for patients to get his or her own data, or make it challenging for other doctors to get a patient's data because I don't like competition, then I could be information blocking. Next slide, please. So why do we care about information blocking? Because we care about improving patient care quality and satisfaction by improving the information access, not just for patients, but also for other providers. And of course, we're also looking to avoid troubles by becoming compliant with the law. And as far as we know, the OIG can slap the developers, the HIT developers we mentioned earlier, as well as the Health Information Network, Health Information Exchange operator with a fine if they participate in information blocking. They can, OIG can take away HIT product certification from status from the developers, and everybody can get some kind of negative PR associated with it as well. The OIG penalties, as of right now, does not apply to us healthcare providers, but there could be what we call appropriate disincentives for healthcare providers, and that's that hasn't, what it actually means. It hasn't been formally decided or announced. It seems could be money, could be something else. Next slide, please. So to sum up, what makes you a information blocker? If you are an actor covered by the information blocking provision who works with electronic health information, and that you know what information blocking is and do it anyways, and there are no other existing regulations that tell you to actively interfere with information access, then you are an information blocker. Next slide, please. Of course, there are exceptions to information blocking. The ONC divided them into two classes. One that involves not fulfilling information requests, and one that involves how one fulfills information requests. Note that when OIG gets a complaint about information blocking from an actor, it will be evaluated on a case-by-case basis. This way, if you don't meet all the exceptions but are being called out for information blocking, OIG may not call it information blocking. And here are some simplified interpretation of the exceptions. So preventing harm. The goal here is to protect patients and other people by not showing certain information. For example, if the patient has wrong data being recorded, then we shouldn't show it to that patient. The privacy exception. So if there are existing local or federal laws, or the patient prohibits us from showing information to that patient, then we shouldn't show it. Security exception, if someone is requesting information but that causes security holes, we shouldn't share that information either. Infeasibility. Sometimes we can't provide information in a way that is requested because we don't have technology to do so, or it's too expensive to do so, or we just don't have the legal right to do so. Therefore, not being able to produce that information is permitted. And then there's the HIT performance exception. So if you connect your EHR to the health information exchange, the network, or third-party apps, means that it will make our EHR crash too much or too slow, that we should not maintain such connections. And then content and manner exceptions. Here is a thing where if someone requests information outside of what's being specified by the Cures Act, or in some ways unfulfillable, like if you just don't have that information, then you don't have to fulfill that request. Fees exception. So it says that we can charge money to fulfill EHI requests, but you can't do it to make a profit or make it to undermine competition. You can't just charge your competition with a fee. You can, if you're on charge it, you have to charge to everyone. And then licensing. This is more specific with developer in the sense that developer can charge a licensing fee or collect royalties to protect their intellectual property. Next slide, please. So let's look at some specific instances. We have questions where a few folks ask about about the preventing harm exception. One of it is, what would be an acceptable occasion to restrict information from a patient? And again, the example they gave was that if you know that the data on a patient is wrong or corrupted or mismatched, whatever, like say a bunch of false positive COVID tests, you shouldn't give it to that patient because that could cause harm. The other question was, what if the organization doesn't allow minors to get their own portal login access because they might not be able to validate their identities appropriately? The rule says that these patients should be granted access to their health information by a way of proxy or legal representative. Otherwise, if you simply don't have the technology to do that, you can try to use the content and manner exception or the infeasibility exception, depending on how they actually apply to your individual situation. Next slide, please. Another question is, what if there are state laws that say that you cannot share some kind of information unless you do complete a certain protocol first? The rule says that since this is required by state law, it's not actually information blocking. You are supposed to do that first. You're supposed to finish your protocol first, then you can release the information. But slightly different is that what if you try to delay the release of lab results in the name of preventing physician-provider relationship harms, or you want to deliver the information only when there is appropriate counseling and context? The rules say that unless you can prove that delaying the information delivery can prevent actual harm, you should not be delaying the information availability. The patient should have the right to choose their information as soon as possible, or they can choose to wait until a provider tells them about it. Next slide, please. Privacy exception here is a kind of a showcase of an intersection between information blocking and HIPAA privacy rule. And to kind of sum it up, really, is that HIPAA privacy rule gives people the permission to share information with each other. But information blocking, however, actually requires the providers to do that. So the example the Federal Register has given is that if a primary care provider and a specialist are seeing the same patients for the same things, the two of them are supposed to be exchanging information even when they are direct competitors. Next slide, please. Here we have some privacy exception questions that are a little bit similar, but the questions are these. So what if the state requires consents from the patient to release certain information. Can you block information until information release until you get that particular consent? And then the second part to that is, does it matter if the patient simply hasn't gotten to provide the consent versus if the patient straight out and tells you, no, I don't want to give the consent. The rules say that information blocking will not override HIPAA or state rules. So you could actually withhold information and not be considered an information blocker. Next slide, please. So this is timeline that's supplied by the ONC. We chopped the top part off because that specifically has to deal with the developers and their certification program compliance timeline. We're only looking at the information blocking portion on the bottom here. And here are some key dates we're noted. So from May 1st, 2020 to February 1st, 2021, this is the time that we understood for everyone to get compliant. The November 2nd, 2020 timeline, that is the time where us, the actors, we're not really supposed to be engaging in information blocking practices. But because of the discretion enforcement time period, we get a little leeway until February 1st. And then between February 1st, 2021 and August 1st, 2022, the US CDI is the minimum definition for electronic protected health information. After August 1st, 2022, electronic protected health information is basically defined the same as the regular protected health information. So that definition will actually expand to encompass more things than just the US CDI. Next slide, please. So USCDI currently version 1 is a temporary alternative to the broader EHI definitions before August 1st, 2022. So they list the type of information that has to be available, but they're not saying that the EHI must be in the standard provided. So if you have, say, a medication list and you have to provide that, you just have to make that available somehow, but you don't have to provide them in the RX norm format that the USCDI specifies. After August 1st, 2022, however, the EHI definition will be expanded to everything that a patient can request via the HIPAA privacy rule from the medical records office. And just a quick note that according to rules, however, EHI does not include psychotherapy notes. That, I believe, is a carryover from the HIPAA Privacy Act. Next slide, please. I want to give a word on Open Notes effort here. It's a collaborative effort to that was ahead of the times as they began studies where they invited patients to read their primary care notes via patient portals starting in 2010. They published their the major results in 2012 in Annals of Internal Medicine, and then they also published another study in the BMJ, British Medical Journal. They found that letting patients read their own clinical notes is generally a good thing, a good practice, and providers don't have to change significantly how they do their documentation. They are mentioned here because Open Notes have a page on the information blocking provision, and they provide guidelines on how to make the clinical notes more readable to the patients moving forward. The website has a list of participating organizations for people to contact each other to seek help and figure out how to do this better. Next slide, please. So now we're going to talk about how we, Stonybrook and Hennepin, differ in our implementation. And please note that these are still subjected to change, and these are what we hear from our respective CMIOs of this time. But yeah, we'll see how it happens. So next slide, please. So in educating the providers and the patients, we need to think about how do we deliver this thing? What do we communicate? Through what channels? How do we address the provider's concern and give them like a forum for feedback? How do we advise the patients and providers what's being changed? And how do we educate the providers on documenting protected note types? At Stonybrook, we are mainly going to rely on individual departments to do the education. The hospital will send out an email, probably from the CMO's office, and also put out a notice of some kind on the patient portal to educate patients and providers. We will be going live we plan to go live with the information blocking implementation on January 1st. So between the November 2nd and the February 1st timeline, so that people can have time to develop practices to improve their child hygiene, reduce note bloats. We are also, and for now, we're collecting feedbacks about information blocking from the providers via our deputy CMIOs in each department. And going forward, we plan to educate about how do we document protected notes, how do data previously hidden or delayed release will become accessible instantaneously. We'll need to also advise providers to be prepared about the fact that now the patients can see information potentially before we do. So how do you mitigate some situations where people might call you at 10 p.m. on a weekend? And I'll let Matt go over implementation and Hennepin.
Thanks. Can you hear me?
Yep.
My name is Matt Kalina, and I'm a first-year clinical informatics fellow at Hennepin Healthcare Systems. I'm just going to try to highlight some differences, and really, we're taking a pretty similar approach to Stonybrook. One of the big things is we had been planning to roll out most of our changes on the November 2nd deadline. Our lab and test release will go live on November 2nd. And we had opened open notes up in the ambulatory setting for medicine clinic, as well as some specialties. And discharge summaries as well, we made open to patients back in February of this year. And overall, really it's caused no extra work. There's been no reports from clinicians of any issues with the open notes. And there's just been some anecdotal reports of patients liking the change. Discussions this month have heated up between department heads, and specifically relating mostly to pediatrics, but also a couple other areas that have caused some concern with opening all our notes on November 2nd. And so our timeline for when we turn on our open notes is now sort of in flux, and it'll probably land somewhere between November 2nd and January or February. So a little bit to be seen with that.
Thank you, Matt. Let's go to the next slide. So we also need to think about what kind of information from what authors is to be displayed. And for Stonybrook, we're going to be excluding documents from nursing completely, as well as physical therapy and occupational therapy. In addition, we will not be showing first and second year medical student notes because those are not billable. For all the other trainee notes, so that includes the third year med students, fourth year med students, the residents and fellows, they will be instantaneously released when they are signed by the authors themselves. For the the specific types of information to be released or hidden, we currently only plan to hide psychotherapy and some other notes, psych notes that we are going to deem confidential. Again, keep in mind that psychotherapy notes are not considered PHI or electronic PHI, so it's okay to restrict access to them. As there was no New York state law governing like other information release between providers or from providers to a patient, we will plan to make all test results available as soon as they're posted. And then again, I'll let Matt talk about what they plan to do at Hennepin.
Thanks. Yeah, and the big difference here is due to some of our state laws. Addiction medicine notes and labs are going to be left out of this and are out of scope. We are going live with open notes only to notes from whenever we go live with it onward. We're not going to backtrack on old notes. So those are out of scope too.
Yeah, actually, I forgot to say that too. We also deem that basically after January 1st, 2021, all new information that's produced after that time will become immediately available. We will not be retroactively going back to say, December 1st and make the notes from that time also available. The next slide, please. So as there are more questions than answers, we're still looking to the community for ideas for best practices due to a variety of interpretations. And from here, we hope to do a little bit of crowdsourcing to see how everyone plans to deal with this. And so, yeah, let's open up the discussions with a few polls. Next slide, please. So yeah, here, let's see. What do your institution plan to restrict any of these following informations from being released through the portal Health Information Exchange? You can put in the poll information here, and then if you have a comment, you can also unmute yourself or post it to the chat to everyone, where Matt will be monitoring the chat box. So yeah, wow. So psychiatry note, yep, that's pretty expected. STD, okay. It's abuse, okay. Addiction treatment, yep. We definitely that's kind of what they some people are talking about, and then others are not sure. And yeah, for those people saying others, if you can let us know somehow, like what are kind of things are listed under others, that would be great.
So this is Jessica Ruff, and I'm at Metro. We've been at Open Notes for I think like 4 or 5 years, and we're not restricting any of this. So we're going totally open.
Thank you.
We already are actually. We're not changing anything because of this.
And there's and let's see. Okay. I thought we were having a discussion on Slack before, and was this someone from your from Metro saying that there are confidential types of information? No.
So it's up to the psychiatrist. It's not a blanket restriction. So the psychiatrist or the pediatrician, those are really the only ones that use them. There is a confidential note type. And if you want to make it confidential, then there's like a whole big thing you got to jump through, but you can if you really want to.
I see. Okay. And we have some kind of follow-up questions about that. And but let's go to the next slide first. Let's go to the next question. So what day is your institution planning to be compliant with information blocking provisions? And as we said before, Stonybrook plans to be somewhere between the two dates, where Hennepin wants to have this implemented before November 2nd. looks like it's kind of interesting that, yeah, we are, we are, people are not sure. Okay. And, you know, what, I mean, I guess the thing I want to open up to the group here is like, you know, what's the rationale for choosing the November 2nd, 2020? And, you know, if you can be um, relatively certain that you can be compliant by that time, what were the, how did you have the bandwidth to do this? Like, when did you hear about it? Because I think our CMIO heard about it like in, I want to say September or October, because previously we were all just being swamped by all the COVID stuff. Again, please feel free to unmute or post a chat to everyone.
So, and we have a number of questions, so we can start addressing them with this too. And some, Feliciano had asked about, do we have a choice of when to go live? Is it November 2nd, or is it February, or is it just somewhere between? And so I think
Yeah.
that rolled into your question here as well.
Yeah, so I mean, so I look at a few places for this kind of information, right? So when you look at the when I look at the Federal Register, they pretty much, they give you the May 1st date when the rule became available, and the June 30th date when the rule went into effect. And they just say, well, 6 months from the publication of the rule. So you had to do it like your own mental calculations to say, oh, okay, so November 2nd is the compliance date. Great. But then if you actually listen to the webinars from the ONC's website, there's actually the 21st Century Cures Act has a specific website dedicated to this, where they posted multiple webinars. And from the web compliance webinar, they actually said that, yeah, you know, you don't actually have to be, so they say, what they say is this, they say, yes, you are supposed to be compliant by November 2nd, right? But the OIG and the ONC are not likely to go around and like start like issuing citations and like fining people, like handing out fines and stuff like that until after they started enforcement. And so that's February 1st. The enforcement date, the discretion date, that was according to this table they made, that was primarily geared at extending the health HIT product certification period for the developers. But because we as the users, we are dependent on the developers, so therefore it's kind of up to the developers to become compliant first, and then we can become compliant. So that's why the February 1st date, to our interpretation, also applies to us. And so we, at Stonybrook, we decided that, you know, we don't want to wait until the very last moment. We just want to say, hey, new year, fresh slate, let's begin. Let's start over. So yeah, so that's kind of how we did it. Okay.
And I think if anyone wants to chime in on what they've seen on their end, feel free to speak up here too, because this is, you know, Hennepin has read it as kind of openly written and dependent upon institutions' interpretation of it. So it's a pretty interesting topic in that regard.
But yeah, is it possible to share where you found that date in the 21st Century Cures Act compliance table? This way it can inform.
Yeah, we have, let me see. We have a table here where, so I think here, are you talking about the regulatory enforcement discretion dates?
Right.
Okay, so I'm going to try to post it here to everyone. So this is and in the compliance webinar, they talk about that. Okay, and then okay, and then anything else that we should go over in the chat box, Matt?
Does that answer your question?
Yes, I'm just reviewing it. So go ahead, please.
Okay. Yes, there's a few more. One question that came in early from Victor Garcia was, if a patient never asks for a specific data element, the hospital never makes it available, is that considered blocking?
So that depends, right? It depends on what's being considered electronic protected health information. To my interpretation, it's that even if the patient never asks it, it has to be available, ready for release, right? So if let's go back to the USCD IV1, right? So on there, it has certain clinical notes as one of the information types. Even if the patient, as a patient, I stay in the hospital, right? Say I got admitted at Stonybrook, I stay here, and I left the hospital. I never bothered to go back and check the notes, what the doctors say about my stay there. That's my freedom. But as far as I understand, Stonybrook has to make those notes available to me whenever I want it. And so I shouldn't have to, and that should be available on the patient portal. I shouldn't have to jump through some hoops to go through like the medical records office to get those information, because the information, to my understanding, is that what you release on the patient portal, that is supposed to be mirrored by what you can release from the medical records office after August 1st of 2022. Between February 1st of 2021 and August 1st of 2022, you can just stick to the list of things that they lay out there in the USCT IV1. Okay.
Yeah, my take on it is, if it's required to be released and you're not releasing it, you would be liable if a patient were to request it, but you would not be fined if a patient were not reporting that they were unable to obtain the information they wanted.
I think the other thing is that they never said that they're going to just like independently audit individual hospitals or survey individual hospitals to see who's an information blocker or not. Like it's not like the public health department checking around individual restaurants to say, oh, if you're compliant or not. Doesn't sound like that's what they're doing. It sounds like they're waiting for people to complain about who is an information blocker, and then they will open an investigation. So it's not like so I think that is also the other consideration, is that you have, I guess we all have a little bit of leeway in terms of like, okay, we have time to make sure we get things ready so that if people complains, we can provide them with the documentation information to say we did everything we can, right? All right. Any other?
Oh, that was for Jessica Ruff.
Yeah, but I'm also waiting to see like how are things going to be with Stonybrook, once they go open notes, right? And even my residency, even the place where I did my residency, we don't have open notes either at the time. So going forward, how are they going to do it? I'm kind of interested in finding out, but we'll see.
Is Jessica here to answer that question?
Yeah, sorry, I lost my sound for a second. What was the question?
In the chat, Victor Garcia had asked what your experience has been having basically full open notes for years now. Do you get many complaints, or what has been the overall experience?
Minimal complaints. And if there is a complaint, then the patient's always allowed to request a change to their medical record. If it's if the clinician deems it's appropriate, then we change it. But I think the times that's happened could probably be counted on one hand, as far as I know.
And then was there any sort of education providers on how to write notes, or is it essentially just be aware that the patients will have access to it, but write your standard notes?
So I wasn't here when they went to open notes, but I would say onboarding after that, we didn't have any, we don't get any specific training related to the fact that we have open notes. I mean, they barely even mention the fact that we have open notes. It's just sort of expected. We don't treat it any differently.
Yeah, and I know from some of our education, that's the message we're trying to give providers, because it's kind of like a shock to some people that, oh, we're going to make everything available to be seen. And it's like, this has gone smoothly so far, and we don't think it's going to be a disruption in your work.
Yeah, I do know that there was a lot of anxiety about it, but it turned out to be a lot of anxiety over nothing.
And Baker also asked, is there any specific reason not to make older notes available? So then you can account, if you do that, and if you make your older notes available before you had a chance to have all your providers kind of line up and do what you ask them to, then you can potentially get into situations where your patient may see unsavory things in the notes. Throughout my residency and in the places I went to, I seen people snipe at each other in the notes, right? Providers saying this doctor doesn't know a damn thing. That's a bad doctor because they made a giant mistake, or what are they doing, or all kinds of things. You don't want patients to see that. That's embarrassing. So that's just one thing. And then the other thing is if you are in a place where people copy and paste notes a lot, and what if you have some older notes that say, hey, on July 1st, 2021, the patient is in the ICU intubated, whereas, if you were actually there on July 1st, 2021, the patient is actually sitting up and laughing and talking to you, right? That's just the wrong thing, right? You don't want patients to see these doctors, what are they doing, right? So I think I think, you want to protect yourself. You make older notes available. I guess you could try to do that, but if you want to, but I think it's better to just make sure that all your providers are kind of uniform in the way they do things. Yeah, and if the patients really want the older notes, they can always go to the medical records office. That's fine.
Out of curiosity, does anyone know if their institution is going to release notes notes retroactively from the deadline? Okay.
Maybe not, or people don't know. And yeah, that's okay. And then I guess the question I have here is does your institution plan to delay release any kind of information going forward, right? Because earlier when we talk about when I show you some excerpts actually from the Federal Register, they say that, well, delaying any information release is not exactly ideal if you don't have a good ground to stand on. So for people who say that, hey, we plan to delay release the information, then my question is, I mean, there's 75% of us that say that. So the question is, what's the justification? How would you justify I think Matt said that at Hennepin, were you guys going to cite the preventing harm section? Is that how it's going to work?
Yeah, we're gonna have we have a button available, and so and preventing harm is the #1 reason it'll probably be used, is what we're expecting. And so you're able to unshare the note with the patient, and then we're gonna have a dot phrase that needs to be used to explain why you're not sharing it.
Yeah. What about everybody else? What do you think? I don't have, we don't have any, at least at Stonybrook, we felt like we don't have any particular good ground to stand on when when the time comes to sharing information, like putting any delays in information sharing. Maybe Jess, like even what's your guys' take? Like, you guys are doing open notes. Are you guys going to make things like immediately available like that for everybody?
So yes and no. We do have some results that are delayed, and I think it's like 30 days. For anatomic pathology is I think the biggest one. We don't want somebody getting their cancer diagnosis through a MyChart result release. And all the rest of our labs are delayed so that they're automatically released at 24 hours. But they are also released when a physician does them. So if you done your lab, so say you got a CBC on somebody yesterday, when you hit done, it automatically gets released. And that's new for us. We just did that in like the last 3 to 6 months or something like that, because our average time to release results was like high based on the Epic benchmark. So that was what we were missing. We were waiting for the 24 hours as opposed to doing immediate release when the physician hits done.
And at Case Western, like, do you guys? It sounds like maybe you guys interpret the ruling a little bit differently than we did. Where like you or are you like, did you have to make any specific justifications about like this is the Ohio law that we have to delay these information release, or are you going to be using any exceptions, you think?
No, I don't think there are any exceptions. I mean, those are our automatic release. So we have like automatic releases, and then we have releases for like when the physician can always release them earlier. But I mean, I think there's a difference between saying like, yes, patients need to have access to their information, and giving the physician or the clinician time to explain what's happening. Like, it's not going to help anybody. And I think it would definitely cause harm to automatically release results without giving the patients any sort of context. And so I think that's how we've sort of come to what we've come to. That was the reason for our 30-day delay, which I think we talked about making it like 2 weeks or something like that, but I don't remember where that conversation sort of ended up. But there is some harm in just releasing information into the ether worlds if you just do it without any context.
And I actually think that if you want to release information, I feel like I feel like maybe most harm comes from when you release information and then patients get caught by surprise. But what if, like, say, you tell the patient that you're doing certain tests, and you are like you say, hey, patient, we're going to do a test to look for this. Whatever results you might see, please, that's let me get back to you and talk about the results with you. And maybe that can mitigate some, that, at least in my mind, that could be one of the ways to like mitigate these like risks for like 10 p.m. weekend phone calls where like people are calling you.
Yeah, oh, sorry, Joe. We're on kind of the opposite end of the spectrum of Jessica, where we're releasing most tests immediately. And then like our pathology, some genetics, and then tests with propensities for false positives like HIV is going to be at 4 days. And labs and imaging is at 1, which is in line with other systems here in Minneapolis. And we're kind of taking the same approach as Chow, is trying to redo the way we do tests, where we educate up front before ordering the test and mitigate some of the effects of finding out the results online. But I completely understand what you're saying. It's just really, it's such an interesting topic.
Hey, this is Chetan from Stanford. Sorry I wasn't able to weigh in sooner, but I just wanted to share an example here. So we've been doing open notes since 2016, not everywhere, but in some subspecialties. And an interesting anecdote we had from a pediatric neurologist was, prior to doing open notes, and when we just released labs, he used to get a lot of messages from patients because they would see the anti-epileptic drug level, which would be above the normal range. And he would get questions, but that is what would be expected. You'd want that high level of anti-epileptic in the blood for good seizure control. And so what he explained was, after doing open notes, he started to put in his notes, like, you're going to see the lab is going to look abnormal, the numbers will be high, but that's actually normal. And so after starting open notes and providing the context of what's expected for the lab, he actually had a decrease in messages. So I think that's part of the potential synergy between notes, having the notes available because they provide context to the labs and other information you'd seen in the portal is part of the advantage. Obviously, you can't provide the context for every lab and predict every scenario, but it could help in multiple areas. And then the other thing I wanted to say too is the preventing harm, the harm exception. One of the points with it is they specifically point out that it has to be immediate physical harm and not kind of more potential psychological harm too. So that's one of the delineations of it that I think is important to keep in mind as institutions interpret this.
This is Ela Singh from Baylor College of Medicine, Texas Children's Hospital. I just wanted to share a couple of points from our experience. We have spent many meetings with clinicians and our legal and compliance folks to work on this, and we're going live on November 2nd. And the 2 points that I wanted to emphasize is, one, we're planning to have a sort of a kind of an initial pop-up note that goes with a lot of these things. So this was based on what MD Anderson, which is planning to release all their cancer diagnoses, et cetera, immediately to their patient. And they're using words which are, I'm obviously, sort of making them up as I go along, but they are essentially something like, we think these results are very important, and therefore we are sharing them with you at the same time as we are sharing them with your provider. Your provider may not have seen these results, but they will see them and they will get in touch with you. So words to that effect. So we're going to include that with a lot of our things, especially with anatomic pathology, because that has been on a 4-week delay and now will become instantaneous as soon as a final result is obtained. The other thing we learned was from University of Colorado Health, and they have an excellent white paper on this whole process. And one of the things really spoke to me was this clinician who said that anytime they order any testing on a patient, they go over all possible eventualities of that testing with the patient before the results. So the patient knows what the worst outcome can be, that there could be cancer, there could be, whatever. So then when they see it, it's not such a shock. And when the clinician finally calls them, they can have a better conversation. Because if you get bad news on the phone, you're likely not listening to what comes next. I know that if I'm a laboratory medicine person as well as an informaticist, I know if I get bad news about some lab test of mine, my first thought will be that, oh, they mixed up the tubes, or something wrong happened, right? So those were helpful as we planned our communication with our clinicians, as we planned what to put as a setup for the person receiving those results.
Yeah, thank you so much for that. I think, yeah, that's really kind of what I was thinking about too, as we, going forward to make information available, right? Like I hear people saying that, hey, we just don't have time in our busy clinic to talk about every single thing with our patients. But that's the thing is like, when I was working in a primary care clinic, like, I mean, yeah, I know that it will take me, an extra minute or two, but sometimes it's just that important to say, hey, we're going to do an A1C today, right? It could be low, it could be high, it could be less than 5, it could be greater than 7. I want to let you know that I will get back to you. And when you see a low number or high number, that's what it means, right? And then we can talk about how to go forward in like what's our strategy. I think that's like you. I think your method of setting expectations for people to know like what to look out for. That's wonderful. Thank you for that.
I can add one more thing if there are any fellows who are pathology informaticists. So the one change that we are making in our laboratories is trying to see that we have better error control methods. Because, if the provider sees the result before it goes to the patient, that's one more person looking out for some error, right? And so especially in the laboratories, if you have things that are very manual, things that are entered manually, you want to now have much better control over those processes because they will go to the patient and you'll cascade these series of events that are never fun.
Well, thank you for that. As we are kind of running short on time, we originally had one more slide that has extra questions here, like are there any specialty notes your institution plan to restrict access to by default? This was kind of aimed at Boston Children's because they, or some people similar to Boston Children's because we got this from Open Notes, and Peter can probably speak to this if we had more time. And then also like we were kind of hoping to hear if there are any laws from the state, any states out there that's affecting your institution's decision to release certain kinds of information. Again, also because New York State doesn't have that restriction, but I think, like Minnesota has. So unfortunately, we don't have time to go into those specific questions today. But just to close up, so I hope at least now that for those folks who didn't know that information blocking is a thing, I hope that know now that it's a thing, it's coming, right? And we need to make it happen one way or the other. There's a lot of questions, right? People aren't not everybody is exactly have the same interpretation of it, particularly probably because of individual state laws affecting it. But we love what we hear today, the people sharing how they see things, how they do things. And I think that's going to be helpful for all of us going forward. And then in the future, we can think about, with all these new information showing up, how do we manage it? How do we act on it? And then in terms of like, our other actors, right? So some people who have multiple roles as different actors, HIE, HIN, HIT developers. How do you deal with information blocking? And do you make sure that everything you're showing out there is consistent with one source versus the other? But again, thank you all for everyone for attending. I hope and we'll make these available on the YouTube, and then also I'll make my slide available because I have all my references in there. Again, thank you, everybody.
Great job. Thanks, John. And Rachel.
Thanks,
Bye,
guys.
everyone.